This 5-minute presentation will highlight some of the key pearls of alcohol withdrawal, including pathophysiology, symptoms, and treatment. The pathophysiology of alcohol use includes 3 main phases: intoxication, chronic use, and abstinence. During these phases, alcohol affects 2 important receptors in the nervous system: GABA, which has inhibitory effects, and glutamate, which has excitatory effects. In acute intoxication, when alcohol binds to GABA receptors, it enhances the inhibitory effect. When alcohol binds to glutamate receptors, it blocks the excitatory effect. This is what leads to the sedation effects seen in alcohol intoxication. Chronic use of alcohol leads to desensitization of the GABA receptors to alcohol and upregulation of the glutamate receptors, meaning more alcohol will be required to have the same effect. When a patient stops drinking alcohol and becomes abstinent, there is a loss of inhibition of the GABA receptors and uncontrolled excitation of the glutamate receptors. This leads to the clinical findings seen in alcohol withdrawal and underpins why it is a potentially life-threatening condition. Now let's talk about the symptoms of alcohol withdrawal. These symptoms usually start 6 to 12 hours after the last drink. They can include things like anxiety, tremor, insomnia, nausea and vomiting, diaphoresis, hypertension, and tachycardia. If left untreated, patients may develop alcohol withdrawal seizures, hallucinations, and delirium. So let's talk about these symptoms in a bit more detail. Seizures from alcohol withdrawal usually develop about 12 to 48 hours after the last drink. Alcohol hallucinosis are hallucinations seen in patients with alcohol withdrawal, and patients are usually aware of these hallucinations. This differentiates it from delirium tremens, which is a condition that includes confusion, hallucinations that patients are usually unaware of, autonomic instability that includes alterations in heart rate and blood pressure, and this is a potentially life-threatening condition if left untreated. Now let's talk about the treatment of alcohol withdrawal, which uses benzodiazepines to replace the effect of alcohol on the GABA and glutamate receptors. Lorazepam and diazepam are 2 commonly used benzodiazepines, and these benzodiazepines are dosed based on the CWA protocol, which calculates a score based on the patient's symptoms and then titrates the benzos to their symptoms. Lorazepam is a short-acting benzodiazepine with a time of onset of 5 to 20 minutes and a half-life of about 14 hours. Diazepam is a longer-acting benzodiazepine with a time of onset of 1 to 5 minutes and a half-life of about 43 hours. This means lorazepam is okay for mild withdrawal, but diazepam should be used for patients with high CWA scores. This is because it has a faster onset and is longer acting. However, it does have active metabolites, so caution should be used in patients with liver dysfunction because these active metabolites can accumulate. Finally, nutrition is an important aspect of care in patients who consume large amounts of alcohol, as alcohol is empty calories, and therefore these patients are at high risk for refeeding syndrome. For this, we make sure to check potassium, magnesium, and phosphate, as well as supplement a multivitamin, thiamine, and folic acid. In conclusion, alcohol withdrawal is a potentially life-threatening condition if left untreated, due to loss of inhibition of the GABA receptor and uncontrolled excitation of glutamate receptors. Treatment is primarily with benzodiazepines that are dosed based on the CWAP protocol and monitoring nutritional status.